Another type of study is an observational study. Here, rather than being randomized to a treatment with a mechanism such as a coin flip, patients are often assigned to the treatment or exposure groups based on their doctor's discretion, and then we observe what happens. This type of design can be cost effective, as we're generally observing practices that would be happening anyway rather than implementing a new routine. Now, however, a patient's probability of being assigned to the treatment group is no longer fully determined by a random process. And in fact, characteristics about the patient often influence their treatment assignment. For example, patients who are older and sicker may be less likely to receive a new treatment due to their current health status. Because we haven't randomly selected patients to receive a treatment, as in a randomized trial, we have to be careful when attempting to draw conclusions from these studies if they haven't properly controlled for all factors that influence both the treatment assignment and the outcome. For example, if we were looking at the relationship between shoe size and literacy, if we did not measure any other factors, we may draw the conclusion that those with smaller shoe sizes are more likely to be illiterate. An important factor, of course, to take into account here would be age, since young children have small shoe sizes and are unlikely to know how to read. These factors are called confounders, and ones that haven't been accounted for in a study are called unmeasured confounders. We'll discuss this concept more in the next few lessons. So let's focus on three types of observational studies. Prospective cohort studies are studies in which a group of people are followed over time to assess the relationship between an exposure or treatment and an outcome. The key here is that the study is prospective, in other words, forward-looking as opposed to retrospective or backwards-looking. In a prospective study, at the time of enrollment, none of the participants have experienced the outcome of interest. Because data is being collected over time, these studies can benefit from many of the positive aspects of bias control seen in a randomized control trial. With a prospective study, we know that the exposure occurred before the outcome, establishing temporality. When trying to establish whether a relationship is causal, meaning the exposure or the treatment causes the outcome, establishing temporality is key. Additionally, with the study design, patient data can be measured at regular time intervals, which controls for recall bias. The definition and measurement of the outcome of interest is also fully in the researcher's control, reducing the chance of biases and measurement error. Because the study design requires enrolling patients and following them over time, it can be more expensive than other observational study designs. Additionally, if the outcome of interest turns out to be rare, the study design is quite inefficient, as the researcher would be waiting for patients to acquire the outcome in order to conduct an analysis. If the study goes on too long, biases due to loss to follow-up will occur. So let's look at an example of a prospective cohort study. This study looks at the association between delirium superimposed on dementia, or DSD for short, and mortality in hospitalized adults. Dementia is a chronic process that typically worsens gradually over time, whereas delirium is an acute change in cognition that can fluctuate rapidly over a day, for example. Delirium is characterized by inattention and disorganized thinking, and it could be manifested by delusions or hallucinations. People with dementia often develop delirium when they're hospitalized or there's some other major stressor. Again, we can quickly find the study design in the methods section of the abstract, and also conveniently the title. This was a prospective cohort study completed in the geriatric ward of a university hospital in São Paulo, Brazil. Reading further, we can pull out key words to determine the exposure and outcome of interest here. So you see the methods section reads, main variables and measures included dementia and dementia severity and delirium. And you can see the tools that were used to measure these outcomes and variables indicated there in the text. Primary outcomes were time to death in the hospital and time to death in 12 months among those who were discharged from the hospital. Comprehensive geriatric assessment was performed at admission, and additional clinical data were documented upon death or discharge. And cases were categorized into 4 groups: no delirium or dementia, dementia alone, delirium alone, and DSD. So the key words here are prospective cohort study. that there were 4 groups: no delirium or dementia, dementia alone, delirium alone, and DSD, time to death in the hospital, and time to death in 12 months for the discharge sample. The first key word tells us the study design. The second set tells us that the exposure of interest is split into 4 categories: no delirium or dementia, dementia alone, and delirium superimposed on dementia. Finally, the study had 2 primary outcomes: time to death in the hospital and time to death in 12 months for those who were discharged home from the hospital. An important set of keywords embedded in this outcome is time to. This reveals that this study has a time to event analysis. We'll learn more about these types of analyses in the statistical models section. You can read the full article in PLOS Medicine. So let's move on to a second type of observational study: retrospective cohort studies. Retrospective cohort studies are constructed after patients have been both exposed and had a certain outcome. Instead of following patients for a potentially unknown amount of time to see whether an outcome occurs, as is the case in a prospective study, a retrospective study already knows that a set of patients have experienced the outcome of interest. For this reason, retrospective studies can evaluate rare outcomes more efficiently than prospective studies. Often, retrospective studies can benefit from large databases that already exist, such as electronic medical records, making them more cost-effective. Additionally, since the cohort is established retrospectively, while we may have lost a follow-up, we know exactly how big this problem will be prior to conducting the study. These pros sound great, but there are also many ways biases can emerge in retrospective studies. Because the research is not conducted prospectively as it would be in a prospective cohort study or a randomized controlled trial, measures may not be taken at regular time intervals or with the level of accuracy the researchers may have used if taking the measurements themselves. The researcher is also at the mercy of the data at hand, as they can't collect more variables on the patients, as they could if they were doing a prospective study or a randomized trial. Therefore, the issue of missing important factors, such as unmeasured confounders, may be more severe. Additionally, while researchers often try to control for temporality by ensuring that the patients experience the exposure prior to the outcome, this can be hard to know as convincingly as it is known in a prospective study, so introducing the issue of temporality. So let's look at an example of a retrospective study. This study looks at the association between using 2 antimicrobials versus either drug alone and surgical site infection as the outcome. Again, we're able to find information about the study design in the methods section of the abstract. Here, the methods section reads, using a multi-center National Veterans Affairs cohort, all patients who underwent cardiac, orthopedic joint replacement, vascular, colorectal, and hysterectomy procedures during the period from October 1st, 2008 to September 30th, 2013, and who received planned manual review of perioperative antimicrobial prophylaxis regimen and manual review for the 30-day incidence of SSIs or surgical site infections were included. Reading a bit further in the methods section of the main text, we can determine the exposure and outcome of interest. The primary outcome was SSI within 30 days of surgery, determined by this manual review process. The primary exposure evaluated was surgical prophylaxis with combination therapy, vancomycin plus a beta-lactam, versus either drug alone. So let's pull out some key words. From October 1st, 2008 to September 30th, 2013, who received planned manual review of perioperative antimicrobial prophylaxis, who received a manual review for the 30-day incidence of surgical site infection, surgical site infection within 30 days of surgery, and then combination therapy, vancomycin plus a beta-lactam versus either drug alone. The first set of keywords lets us know that this is a retrospective study. The first lets us know the range of dates in the past that were considered, October 2008 to September 2013. The second lets us know that the exposure status was established prior to cohort entry. The third lets us know that the outcome status was established prior to cohort entry. This is what makes the study design distinct from a prospective study, where the outcome would be unknown at the time of cohort creation. The fourth tells us that the outcome of interest, SSI, within 30 days of surgery. And then finally, we learn the exposure of interest, combination therapy, vancomycin plus a beta-lactam versus either drug alone. You can read the full article in PLOS Medicine. So let's move on to case control studies, the final type of observational study that we'll talk about. Here, cases are established as patients who have the outcome, and the controls are patients who do not. After selecting the cases and controls, the researcher looks back to the established exposure frequency in each group. This makes case control studies retrospective in that both the exposure and outcome status are established prior to study entry. Note that this differs from a retrospective cohort study in that patients are enrolled based on their outcome status, whereas in a retrospective cohort study, while the outcome is known at study entry, patients are not included based on which outcome they experience. In other words, case control studies start with the outcome and assess which exposures may have caused it, whereas cohort studies begin with the exposure and try to assess which outcomes occurred as a result. Because the outcome status is used to select the cases and controls, this study design is well suited for rare outcomes. Case control studies, though, suffer the same issues as retrospective cohort studies. Additionally, it can be hard to select an appropriate control group. Let's look at an example of a case control study. This study is examining the relationship between myocardial infarction and alcohol consumption. Examining the methods section of the abstract, we're able to determine the study design. Our hospital-based case control study comprised 374 participants, 187 newly diagnosed patients with myocardial infarction, and 187 controls, individually matched by gender, age, and place of residence. We can pull out the following keywords: case control study, myocardial infarction, and matched. The first indicates this is a case control study. We then learn that the outcome of interest is myocardial infarction. Finally, we learn that patients are matched by gender, age, and place of residence. Matching is a common way to control for bias in observational studies. It's crucial to understand where the controls were selected from in order to assess the validity of the study. This can often be found in the methods section, in this case under the study population subsection. You can read this full article on PLOS One.